Okay, so Asan Medical Center is ready. Again, I would like to encourage everybody to quickly come up and take their seats. Yeah, because once we get rid of this, it gets difficult. But we're getting, no, here, this tells you where to sit. Okay, enough. So if we could go live to Asan Medical Center and please change the monitors so we can see what's happening in the cath lab.
Okay.
Hi, it's Jay. So we are all here on the podium, Gary, Mintz, and myself, and obviously the panelists are all on the deck, and we'd love to finish up the conference with you, and maybe you can help us get started.
Thank you, Alan and Gary, and good morning, everyone. Almost there. So we are preparing last case lab demonstration from our hospital. So this case is also a lab main disease. Yesterday we discussed a lot about the new study. Dr. Bach discussed about that, main study, angio guided and FF guided. Anyways, we want to make some, new data for that. And so, okay, would you show us angio first?
Yes. So
And then introduce
okay.
case.
So I'm D.W. Park, and our second assistant is Junghoon Lee from Seung-Ho Hospital, and the senior fellow Han-Soo Park. So, and Han-Soo, can you present the patient background first?
Yeah, thank you. This case is 59-year-old male presented with effort-related chest pain. He has been treated with stroke and dyslipidemia. The coronary angiogram showed diffuse stenosis at proximal to mid portion of RCA and diffuse stenosis at distal left main to mid LAD. This PCI at RCA was performed 3 days ago, and we planned revascularization of left coronary artery. Next. His medical history is dyslipidemia and stroke, and his clinical presentation is stable angina. Next. ECG showed no significant STT change. Next. Chest X-ray showed no pathologic finding. Next. Echocardiography showed normal LV function without regional wall motion of normal lipid. Next. Baseline RCA showed diffuse stenosis and proximal to mid RCA, so we put the stent, synergy stent, 3.5 diameter. Next. Left coronary system showed diffuse stenosis along the left main to distal mid LAD and erythema change at diagonal bifurcation. Next. And next. Target region is distal left main bifurcation region and proximal to mid LAD region. Intercoronary image is IBUS, and we can choose the physiology study with random.
Okay. Random.
Yes. So, and can you show us the first coronary angio view here? Okay, so, and this is the arterial cranial view. You can see there's some prox LED part, there is some aneurysmal change, and just below the prox aneurysmal change part, there is some stenosis. Also, distal leg main is you can see there is some stenosis. And next one. So, and this is a spiral view, and you can see the distal leg main or is significantly narrowed, and the subosteum looks okay. There is some, fistula. Next one. And this is the areocaudal view. You can see the distal leg main, and from the main shaft there is a significant stenosis, and the subosteum is okay. And next. So, and this patient was we do, and for the left main disease randomization enrolled in FATE main trial. This patient is randomized to FFR group, and we also measured the FFR. And,
Just
okay,
before that, anyway, as you see, truly leg main bifurcation, right? Anyway, circumference team is good, and right shade disease and main with multivessel disease. We cannot measure the syntax score, right?
Initial baseline syntax score, did you measure?
No. All right. Anyway, this is our policy concerns. If the lesions, other epicardial artery suitable for, stent, we do stent first, and then recently we just started new, study protocol for main, and so. All right. So would you explain the FFR concern? So we measure the FFR first.
So, and we measure the FFR, for measurement, the left main disease, absolutely the zeroing at the guiding casta is, hanging out. The left main is the essential part. And then after zeroing, we measure the FFR is, as shown in this figure, from the LAD to the left main and diagonal to the left main. And from the LAD and the distal part is in hyperemic intravenous adenosine hyperemic state is 0.57 and slowly pull back. Some aneurysmal part 0.69, and after pull out that the left main ostium is 1.00. So, and delta change is much significant in the left main part. Also, we pull back again the diagonal part. The diagonal part is 0.59, and then aneurysmal part 0.69, and then 1.00 in the left main part. But the diagonal branch is not so big, and the ostium looks okay, and we decided to just stent crossover, and then some blah blah blah.
Okay.
Yes.
Before that, anyways, we clearly showed that diagonal distal FFR 0.59 and 0.57 LAD concern, and so we have to consider kind of a tandem lesion concept. If you look at delta FFR value between the proximal leg main and LAD, almost 3.3 something, and if you calculated delta value from the just the proximal LAD to distal, it's just 1.11, and so we clearly know that proximal part of distal leg main and proximal LAD disease is main disease. So anyways, we've discussed a lot. Which one, how to, how do we treat, this lesion based on the FFR? Would you suggest and discuss something more? Dr. Gu, Bon-Kwon?
So SJ and Duk-Woo, maybe we can ask the panelists a little bit in terms of their approach. And I think the tightest lesion is actually near the ostium of the LAD, and then obviously extends into the distal left main. But the two numbers in the LAD and the diagonal very similar, right? 0.57 and 0.59. It tells us that the disease distal to the bifurcation of the diagonal to an LAD is really not very much, right? Because it's really 0.69 dropped to 0.57, so it's 0.12, and the diagonal similarly, 0.1. So those two lesions probably doesn't need to be fixed. So what do people think? How much do we want to stent here or fixed? Is it, and how do you evaluate it?
I think what we know about serial assessment of stenosis, tandem stenosis by FFR, that one lesion affects the measurement of the other. So we should not deduce from this single measurement that we should also treat the distal gap, the distal
Lesion, yeah.
lesion. We should go for the severe lesion and then reassess distal. But stay away from going beyond the first diagonal in the first attempt and maybe then reassess the physiology because it will affect the measurement.
Yes, so I think that's a good point. So that the Asan Medical Center already, long time ago published the rule of delta strategy, so that when there's a tandem lesions, fixing the largest lesion first, because at left main to LAD it's almost 0.3, so huge decrease in the pressure. And as Dr. Werner said, excuse me, as Dr. Werner said, that the delta of the distal lesion, 0.69 minus 0.57, will increase after fixing the primary lesion, but we'll see how much will be improved. And this patient have also diffuse myocardial bridging, and above that, very focal, looks like intermediate stenosis, and we'll see. But anyway, it is very straightforward that the distal left main and proximal LAD should be treated first.
I mean, to be devil's advocate, I'm not sure why you should do FFR in this case at the start, because you're going to treat the left main.
Yeah, so
It's
of course.
randomized to the
Oh, it's
arm of the-
randomized?
Yeah,
Okay.
randomized to the arm of the
randomized
FFR.
to the
main trial.
Yeah.
Okay, sorry.
Yeah. So, all right, so just that you recognize the difference from the proximal LAD, distal LAD. Dr. Gu just, correctly commented about that. We're going to show the arms first, and then there are some, breaching, mid-portion of LAD, and there are some disease of, diagonal branches. Anyway, distal, 0.5 and 0.59 actually is mainly influenced by the proximal main disease. We know that. So, I was supposed.
Yes, this patient was a randomization phase main trial is randomized to FFR guided, and so FFR showed a significant reduction of the flow and decide to the PCI. And we are the decision was already done. We check it up the IBUS from the we're gonna show us the mid
So it's the
area.
IBUS, yeah.
Before you do that, I have one other question. There's this fistula coming off
Yeah.
the distal left main or proximal LAD.
Yes.
How does that
This
affect?
already
Okay,
is normal
so-
looking and
Okay. So this is a gorgeous muscle bridge.
Yeah, myocardial bridging part.
I mean, this is as good as it gets.
we can see the 3.0 millimeters for distal LAD region, and now the plug is coming.
So we
this point you can
didn't see enough to measure the thickness of the
Here
bridge.
is the
muscle over it,
and the proximate transition zone, and just the distal part of the diagonal branch. Diagonal branch is coming the
1 o'clock and with the
o'clock.
angiographic change, and we can see the we can see the plug with the angiography, and the plug is coming, and plug with the superficial calcification. We should consider the pre-dilation, and this is the very significant portion. Maybe FFR is reduction from this point.
This is proximate distal main. Here is distal main.
Yeah, circumflex is
okay.
from 11 o'clock. And the lemon is also plugged with the superficial calcification. You should consider another predilation. And this patient is a long main vessel. It is also a left main diffuse with the superficial calcified plug.
So, and we're gonna show again just bifurcation distal part narrows the portion is bifurcation.
Yeah, before you do that, could you start the run and just show people what a muscle bridge looks like so that there's no end? I mean, it doesn't, it's so good.
myocardial bridging.
Start the beginning of the run.
Yeah.
아주 처음부터 하지 말고.
So the muscle bridge, people may think it will affect the FFR, but most of the time, unless it's really, really long and really severe, it doesn't really affect the overall average FFR. You can affect the diastolic FFR, especially if you infuse, for example, dobutamine. So here, I don't think you necessarily think that the average FFR you actually measure is affected by the muscle bridge.
Yeah, but to emphasize what Alan just said, stop thinking about muscle bridges as being problematic during systole.
Yeah.
They are as problematic in diastole because they do not relax.
So after we already infused the bolus nitroglycerin, this is a part of the distal mid-LED bifurcation is a distal part. Is a plaque with a severe is a run. Okay. run 해봐. 그냥 run. Okay.
Okay, another, what, I was again, diagonal branch?
diagonal 아래쪽 아까
That's the lead, diagonal branch.
Yeah, this
여기서
point
block
is
play.
just distal from the bifurcation region. And just please play. Okay. And a diagonal branch is coming from 1 hour clock. And the aneurysm change with the diagonal opening is very preserved. And this is just proximal to bifurcation region.
Okay, move on the diagonal IVUS, please.
Okay. diagonal diagonal.
Okay, luckily,
Yeah, this is diagonal branch, and we can see the plug in the distal region, and we can see the
distal part is small, right?
yeah,
So,
proximal from P4, please. Okay.
okay.
Then we can see the diffuse a smaller plug is we can observe with non-calcified plug.
diagonal branch vessel size is just 2.0.
Yeah, not
big. Yes.
not that big for the stand implantation, and this is the
Most narrow
yeah narrow part. And coming to the bifurcation.
So diagonal ostium is it's not here. Then diagonal ostium is relatively okay.
This point is now we can see the diagonal opening.
Here is diagonal ostium.
Yeah,
Yes.
no plug. We can see. We can't see the plug in the diagonal.
What's the part of diagonal branch is okay, right?
Yeah.
All right, anyway, the delta FFR value is 0.59 and 5.7. LAD part may be related with, muscle bridging. So, and diagonal branch, maybe there are some, disease over there. However, the difference is not so big one. So the reason, reasoning. So we want to start just, okay, why not? We're going to do
The tangible
balloon
load.
force.
So and I think some and we are on the basis of FFR we decide to we're gonna treat the PCI. So and then in the Fate main trial so for optimization the imaging was allowed to be in the both group. And we treat the LAD. So is there any opinion about how they treat the diagonal branch and any different opinion from the panel and the,
Anyone want to
you
comment?
you want to treat one or just leave it alone?
One quick thing first, you did not IVUS the circumflex, right? Because you're comfortable enough that it's wide enough that you don't need to look at it. The circumflex origin.
Okay.
This is a 3.0, the
want to-
NC balloon. Okay.
Contrast, please. Contrast.
So Dr. Koo, so do you, when you have the FFR like this, right, do you look for a particular FFR proximal to the bifurcation that you want to aim for? Because if you get an FFR of 0.94 after the stenting of the left main and the LAD, then whatever happened to the LAD and the diagonal should be greater than 0.8, right? Because if you cannot get the stent in the lumen in the left main LAD to be better than getting an FFR 0.94, you might end up being a problem distally.
Yeah.
All right, play.
Split and 12. 14.
5 seconds. Okay.
1, 2, 3. 자,
Play.
split.
Yeah, perfect. The reason why you want to wait a little bit, I think it's okay. Contrast, please.
Faster.
Hold on. Contrast, please.
Dr. Gu, do you have any data of any myocardial breach affect the FFR?
Yes, so long time ago, we analyzed the influence of myocardial breaching. First, resting condition. Second, after dobutamine stress condition. So we found that, as we just mentioned, that the degree of systolic compression didn't influence the FFR, but residual stenosis at the diastolic phase really mattered, so that it exactly matches with the Mintz findings.
I mean, the work done at Stanford by Jennifer Trammell is fabulous.
Yeah, I think so.
All right,
Really
so
have
we-
to understand physiology well and systolic phase, diastolic
Right.
phase, and what actually stimulate the, is not giving adenosine, obviously, if we look at diastolic ratio type of. So from your ultrasound, SJ, what is the length that you need to treat from the left main to LAD?
Yes, and by IBUS measurement, and the regional length is 36, and we decide to 38 synergy stand. And the T-star EEM was 3.0, and the proximal is big, and considering the size difference, and we select the 3.0 synergy 38, and then we're gonna do further dilation.
So, Dong-Wook, are you fixing the LAD beyond the diagonal bifurcation as well?
Yes.
I see.
And,
Okay.
Right. Exactly. And so we choose a 38
synergy.
long stand
Yes.
to cover the just the distal part of the diagonal branches. And okay, maybe this is quite enough.
It's really important to avoid the muscle bridge, particularly when you're placing these long stents.
That's the important part, is really not to stent the muscle bridge. So that's why I was a little sort of question is, do we need to stent the LAD beyond the diagonal bifurcation? What do people think?
What is the nominal?
I was
That is
wondering
not a
whether,
particularly big gradient, right?
Yeah.
Alan, I was wondering whether we should have repeated the FFR after
Okay.
we
Yeah, you can
made
always
that
add a
adjustment.
stent in if you want, and be more precise at that time, because if you're long stent, you're committed a particular
Correct.
length.
Yeah. And then you have to treat the diagonal as well with a
Yeah.
DCB or something.
The other option may be that putting stent before that kind of ectatic segment, avoiding the overlap for the branches, and if needed, kind of DCB treatment for that focal lesion may be an option, because stent will cover the breaching segment anyway with this very long one stent strat.
Yeah, for the step down of the FFR of 0.1, 0.12, I thought the initial approach would be fixing the left main LED and
Stopping before the
and then
bifurcation.
see what, yeah, and then see what you have.
All right.
After that.
Anyway, there are some, big size discrepancy between the distal part of the 3.0. Main part is at least more than 4.5, and so you're gonna do high pressure inflation for the distal part first, and then using the 3.5 something, bigger balloon, we're gonna do.
So-
And this is 3.0 first, and for distal part. And as you mentioned, Gary, and we would like to avoid some damage of the myocardial breaching zone.
For the audience, if you stent into the bridge, you run the risk that the stent will be collapse during follow-up, and you'll have very difficult to treat restenosis, totally based on an unnecessary mechanical, mistake, let's call it.
So Gary, you asked the question of the role of the fistula.
Just a minute.
Most of the time, even horrendous looking fistula is not physiologically significant. So I would say that here, I cannot see exactly where it come off, maybe distal left main, proximal LAD. Most of the time, nothing to do.
B는 얼마나? 3.5.
More.
20.
20,
It's
24.
a fistula, yeah.
What is the final balloon diameter?
It may be
24.
gone after stenting.
24.
Yeah, so if you happen to have some plaque around that area,
Yeah.
it'll
3.5
hopefully
좋아요.
close it, but never know. Because there's so many usually entrance to these fistula that you may not see all of them, so.
3.5?
Yeah, 3.5. So, and this is a 3.5. So, and how about the opinion about this, superficial calcium was seen in the IBUS and is for region preparation and the opinion from the panel in the, you're going to use just the NC balloon, any opinion for use the, plot the modification pre-dilation like a cutting balloon or scoring balloon or the subtrophy, any opinion for?
Usually we just use the non-compliant and regular, semi-compliant balloon and prep those areas. It was not completely concentric, and I don't see any reason to use lift or IVL or anything like that. Just adding to the cost of the procedure. So this is 3.5 SJ and Duk-Woo.
12. This is 3.5 NC balloon.
And
Actually, the aneurysmal size was 4.0 in the
So,
IBUS.
and this is a good point. Okay, 3.5, 20,
24?
24. Okay.
얼마?
3.7.
Almost 4.
Deflate.
Almost 4.
So at the aneurysmal part, although we're gonna use the 4.0, it's not easy to full opposition. This is 24.
We don't expect full
Yeah,
opposition.
yeah, we don't expect, yeah.
Areas, however,
Okay, deplete.
I think it's good.
This is, we're gonna inflate 24. 24 size is 3.7.
The common teaching was when you do a left main stem, you put 2 wires in and make sure that there is 1 wire in the circumflex. Nowadays, one can be daring enough to forget about the circumflex.
Usually we, for compulsory reason is to put a wire in the circumflex and IVUS it. And if it looks really wide open, then it probably doesn't
Yes,
matter.
yes, that is a critical point. Yeah, that is good point. So, and the angle is narrow and there is some significant disease. We usually put the wire in the post branch. Angel, ready?
Take a picture first with the perfect. I like it.
Another view. Yes, we will check it out.
Show powder.
And spider view.
Yeah, it goes into a big loop.
A little bit decrease the amount of shunt.
Yeah.
Wow, it's almost to the bridge, right? Avoiding the bridge. You can see nitro and making the bridge more exaggerated as well.
It makes sense. Okay, we want to see the austere part of the circumflex. It's really okay. I think it's
Yeah, angle is, this is maximal angle.
아래 AP 카우더 정도로 가고 almost there. Oh, no. More area. I think it's okay, right? Good, perfect. You want to say, a little bit more detail in circumflex austere? Good, perfect, right?
In your trial, DW, do you actually do FFR at the end? Do you actually check an FFR?
It's
Just the guiding at the beginning.
we just use the treatment decision. Yeah.
Okay.
And the audience want the first official FFR, we can do that.
Yeah, it'll be very interesting to see what the FFR is, in the LED, and maybe even diagonal, but I don't want to.
Important point, right? Even in diagonal branches, LED, there may be not too obvious.
우리 FFR 나온 거 있죠?
The issue is traditionally we have not used FFR post-stenting to guide anything.
Yeah, we will measure.
So,
Okay, first we're gonna show us the IBUS.
IBUS from LED.
So again, you're seeing the muscle bridge. And so what we look for is the distal edge of the stent and its relationship to the muscle bridge. And okay, so the muscle bridge is gone.
Here,
Now we see the distal edge of the stent.
So
that's good.
This landing is good, right?
Yes.
Some malposition.
Yeah, it could probably be a little bit bigger, and there's some malposition. And then we're across the diagonal right here.
Yeah, this is aneurysmal part. Yeah,
And
this
this
is
is small.
absolutely not easy to.
It's all a little small.
All right. We need
That's what Alan just told me.
Okay. very proximal part we deploy the 3.5 high pressure up to the 3.7 something, right?
That's the circumflex. Now into the distal left main.
Stand up position is good, right?
Yeah.
So far, the left main minimal stent area is good. It's what, 1, 2, 3 to 4, so it's, you know, somewhere in the 9 to maybe 10, 11 square millimeter range. And then we look at the proximal edge, and
What is it?
Good, landing zone.
and a lot of,
Oh,
and now we're
yeah,
getting to,
yeah.
you know, the very proximal struts that you see there are malopposed. Oh, this is a lot malopposed.
we need
Yeah,
four,
yeah.
four,
Bigger
NC4.
Okay, 4. Okay.
Actually, the clinical, you know, outcome concern is some those kind of a big vessel, a little bit malposition. I think it's not a big deal, right? However,
Yeah, we're gonna do additional.
Again,
was concerned.
for the-
Anyway,
For the audience, that degree of malposition at the proximal edge does not affect restenosis or stent thrombosis or outcomes.
Right.
But if the patient comes back to the lab and you have to rewire the LAD or the circumflex, you've got
Yes,
a
yes.
good chance of getting your wire behind the stent.
Absolutely, yeah.
Can you
There was some chance, you know, or luminal, the wiring.
effective stent area concern is quite enough. However, you're gonna make it more complete, you know.
And if you think you can avoid it,
Very proximal part, those.
No.
Yeah, I think it's from here.
This is a 4. This is a 3.5.
What is nominal?
12,
12.
just 12.
Just 12.
so what size is this?
4.0.
4.0. 4.0.
So using it to dilate the
Deflate.
I don't know.
It's not completely in the LED either, though. I think.
I don't know what they're doing.
This,
Okay,
here. Okay, inflate right now.
20. 4.2. 20. Deflate.
One more.
This is a workhorse wire, right? It's not the FFR wire.
Yeah, this is the work, the Hyun blue. Okay,
Just one. Okay, inflate.
20. 24, 맞죠?
24.
4.2, 24. Okay, deflate.
This is quite enough, right? And then we're gonna do a little bit further. I wanna make another inflate just a minute. Okay, here we are. Another inflate.
Inflate.
One more.
20.
Very enough. Okay.
자, deflate.
Yeah, I think it's important to make sure that you inflate it into the aorta. So you pick up the very proximal edge of the stent.
Yes.
Yeah, you can
Okay,
really see it that well.
24.
So that's
do
probably, that's good.
26.
But a 4.0 balloon is too small.
Well, they said, they're going to
Almost
pressure that they
4.3,
say
right?
Yeah.
should be
We
4.2.
apply
But you're right,
26.
it's too small.
You need 4.5,
Right.
at least.
And 4.5 at nominal pressure. You don't have to use high pressure.
I was supposed to go 그다음에
Because there's nothing to
diagonal
spread
jump.
except
Okay, 그러면 diagonal and LED
too
rows.
hard.
Well, you're displacing blood.
And it's safe, even if you stick it out a little
Yeah,
bit,
yeah.
nothing happens too much.
Okay, I'm
보세요. We check it up IBUS again.
Will you go up with the balloon size for the
It's a
ostium?
4.0. Yes, 4.0. We inflated up to 26 ATM. Then make sure it's a 4.4.
Yeah.
But you measured 4.6 to 4.7 in the
yeah.
ostium. So
So-
that will be not reached by this 4.0.
And I would argue that a safer approach is a bigger balloon at lower pressures,
뒤에서 보고 봐야 해요.
rather than using a 4 millimeter balloon at very high pressures.
메인을 조금 빼놓는
I'm again.
Just take a short 4.5 and just 8 atmosphere, 10 atmosphere.
Okay.
Perfect.
But, you know, it's okay. Still see the bridge a bit.
Yes.
Sister.
So the bridge is gone, and now we see the stent.
Yeah.
It's a little
I
bigger.
think it's quite good. You know,
Yes,
stand
yes.
area wise is more than five. Pretty much stand diameter is
Diagonal
so much
at-
width.
Austria, yeah.
Upper right-hand corner.
I think this area has been dilated to 4.
Yeah, and there's a little bit of nerd, so I wouldn't totally perseverate about the measured area. And then we come
Yes,
to the
this is,
circumflex at the
Yes,
left.
coming.
And now the only issue is what's happening at the proximal edge. You see the stent is
Yes.
super expanded. I mean, it's up,
Yeah.
you know, it's like what, probably 16 or so
Alright.
square millimeters.
You can clearly see what happened in the very proximal part of the stand position. Okay, almost there.
It's fully, we inflate the 4.0 up to 26 and make sure 4.4.
If physics is true,
It's good. Yeah.
fixed. Mellow position. Yeah, there.
There would be some position, but it could be
Not
allowed.
much though.
Don't
Not much.
Duh.
get
It's
out.
fully expanded.
It's not even physics, it's like measurements.
All right, I think. Gary, do you like it?
No, I don't like it. So,
Right.
you know, so
So you
I'm
want to
sitting,
make
and we're, you need to use a bigger balloon at lower pressures. And I would even argue you'd probably use a 5 millimeter balloon at about 6 atmospheres.
Okay. Picture first. Okay.
Yes.
Ooh, big battery.
Yes, yes.
I'm very happy. As why not? FFR. For
FFR.
the digital LED.
So as commented, Alan, we will, as many audience interested how the FFR, there's some changes in the diagonal branch. And
So-
before
yeah.
fixing the main diagonal branch's FFR value was 0.59.
5.9.
5.7.
5.7.
Actually,
Digital LED, right?
0.59.
Maybe I think it's a point guess about Dr. Wu guess about the FFR. Point.
I usually hate to do
something.
that, but I'm voting for
Just
0.8 something, 83 or 84.
Are you going to do the LED first? FFR the LED first? That might be interesting to see what the LED FFR is first, meaning that you have fixed the stand, you fix the LED lesion, just the transducer just distal to the stent, so we don't want to have any component of the bridge, even though it's probably very small. But
테스트 한번 해주세요. 맞아, LED.
그래도 와요.
네.
I wonder in some of these, your protocol, you can probably leave the FFR and the LED, and you don't have to deal with all this.
Yeah.
Because
Yes, we
it seems to be
remove
guided by
LED
FFR.
wire. 그다음에 하고 이제 제로잉 해야지.
And these doesn't need really big support or anything like that.
됐어. 잠깐만 LED 와이어 뺄게. 처음부터 빼.
So the LED was distal is 0.57 and the LED diagonal is 0.59. So before stenting, of course.
유머를 주고.
Let's see what. So
하나씩.
but what did you guess the LED FFR is distal to the stent?
Distal to the stent or whole LED? This LED?
Maybe don't count the bridge, right? Just maybe a little
Right,
bit.
right. So that the first guess, my guess will be if our this LED, I would say 0.84. And the proximal to the, just distal to the stent, it will be 0.93 or 94, 95.
Gary, any guess? What is the FFR?
Nope,
Don't want to guess.
don't want to guess. Don't want,
Point 9.
0.9?
also don't.
들어가고 있지. 제로잉 와이어 빼고 제로잉 할게요.
So the
current white
FFR is never the best still,
Yeah.
so equalizing.
뺄게. 가이딩을 또 뺄게.
컨트롤, pause.
가이딩을 더 요 정도. 행잉
컨트롤?
정도로. 거의 베스트 아웃이야. 정도.
All right, very interesting, right?
셀라인
This
프러쉬
is mainly,
제로에.
mainly influence of muscle bridging, right?
Okay. It's nearly guiding cast the tip was hanging out the left osteo and then zeroing,
Yeah, let's equalize it.
equalizing.
Great.
Okay, 됐죠? Then we're gonna pass the FFR. Okay, diagonal is the first pass. 잠깐만 있어봐. 위치가
So-
똑같은 뷰지?
That's diagonal first, right?
Yes. 테스트 해도 되나? 잠깐만 있어. 기다리겠습니다. 네. 똑같은 뷰로 가야 돼요. 똑같은 뷰.
There's absolutely no reason why these wires should be this big.
이게 자꾸 사이드 빠진다. 테스트 해봐. 셀라인
Maybe a little contra. Yeah, little in the branch. Yeah.
Okay. Yes.
Good,
French. 테스트.
just,
I think you need to come more proximal. Yeah,
Okay,
there you
good.
go.
sure. Oh,
자, here 여기서
Okay.
다시 셀라인하고 introduce 뺄게. remove introduce. 셀라인 프러쉬 다시. 그렇지? Okay, we just wait. Baseline.
So PDPA is 0.9091,
okay, other one?
93
이제
maybe.
됐지? The baseline was 0.94, and then we're gonna induce the intravenous, hyperemic. Okay. So and the gas panel 0.94
I think
after left main fixing.
That's it.
if your
you know,
stand has
the-
fixed everything, there should be usually the
Yeah,
stand
yeah.
maybe 0.95, 96. That's a big vessel, so probably as good as 0.97. So you drop another 10, so back to 0.87,
Even,
85,
Okay,
86,
이쪽에
85,
조금만.
86.
no, 이렇게 하는데, even there are some, diagonal disease, actually the
Yeah,
FFR
yeah.
value is not, significant, not
Here
below
comes-
than the point
It's a hyperemic is induced. Okay.
Ooh,
Okay.
I
We're
think it
gonna
doesn't matter, 0.79, 0.78.
7 over here.
it could be do a pullback when you're ready to see where
the
the yeah.
Okay, here would be these are part of the diagonal branch, and then slowly pull back over here, 0.79, and then we will pull back the
Already.
ostium of diagonal branch.
Yeah, stop
It's
there.
0.92. Yes.
Yeah.
Further,
Further, here is a 0.87,
Okay,
and
alright.
here would be nearly the
okay, LED.
So at
Or
this,
LED.
and I'm gonna go ahead this part of the LED. That will be
Alright,
most people is very interesting.
Very
지금 아들은
interesting.
주고
Very
있나?
interesting.
네, 주고 있습니다.
스타일했어, 오케이.
잠깐만, LED 한.
Well, this is exactly what with the left main stenosis, LED stenosis, the distal FFR falls
좀 더,
meaning
와야
it would be
Yeah,
lower than
yeah, in
40.
the tandem lesion, yeah, proximal lesion, crosstalk
너무
happens.
밀킹까지
So
이제 다.
when you get a
아니,
number of
그래야지
0.77 and
우리가
diagonal,
보는
either your
거는
stand was
브릿지를
not well
보는 거기
done,
때문에
or actually
Yeah.
오케이,
diagonal
오케이.
disease is more severe, right?
자, 하이프레미야? 지금 뭐야?
Don't have play.
넌 하이프레믹이야?
Start.
스타트 고.
Very good case.
이게 non-hyperemic.
Yeah, so baseline is 0.92, 0.93 baseline. Okay, we're gonna start. Okay, it's far distal FFR is 0.95.
Adenosine infusion.
Yeah, adenosine now is infusion 들어가고 있지. There's no change yet. Diagonal branch FFR did not match the panel expectation.
I was wrong in the sense that I forgot that, you know, the LED left main stenosis was pretty severe, and therefore limiting the distal diagonal FFR should be lower than 0.59.
들어가고 있지. 0.83 and A4. Yes, and slightly pull back. 0.84, and this is some milking zone, 0.87.
Just below the stem.
Yes, just below the stand over here.
Here.
Over here is
0.92.
94. 94.
And
just
then
and then we're gonna just the stand is 0.94, and the middle stand is 95, and just the pull back the lemon ostium is nearly 10.
Okay. Great.
Very nice,
you know,
actually. This is
clear information from the post-scan FFR. LED is 0.8.
A4. Yeah.
3,
Yeah,
okay,
A3.
A4,
Yeah.
and diagonal branch is 0.77,
Yes.
right? So you can clearly see that influence of the much bridging
Yes,
is
yeah.
clearly, decrease FFR. And diagonal branch, I think, is a little bit significant.
Yeah, yeah.
However, all right, from the panels, would you treat the diagonal branch one?
I guess many panels,
Right?
Yeah.
some complex idea about the
Treat-
diagonal branch.
Okay, treat, not to treat. Diagonal branch.
I
If
would
you
like to hear
measure the
people say-
FFR and it's significant, you need to treat it.
다이고널을 한 번 더 찍어서 깨끗하게.
Okay, right now.
It's for clear make decision. We're gonna show again diagonal branch angiographic stenosis test.
It was clear on IVUS that was pretty significant.
Area really
Small, but in terms of in terms of the area.
Yeah, perfect.
Here.
All right, so would you treat them diagonal branches
Okay.
or not?
So
How-
we treated the
how
right
many-
coronary, we treated left main LED, though all those were the very severe lesions. And so what do panelists think? Should we go through the strut, open up the strut, fix the diagonal?
No.
Anybody?
Medical
Yes,
therapy.
why do you do the FFR? The first diagonal is a significant branch that we know. And probably you will not have any problems with the ostium because this vessel is big there, the stent is well expanded. You don't even need to cover probably the ostium of the diagonal. You can just leave the stent and avoid a bifurcation.
Yes, you mean the Professor Werner is stand just the middle part of the diagonal branch.
So another opinion is
yeah.
just leave it alone.
Just leave it alone, and the DB additional stand.
I personally, this is BK, so I personally think that it's fine to leave it alone because when I see the IVUS, so that there was a negative remodeling on those lesions except for the proximal segment, so that it looks very big, but the IVUS vessel size at the distal lesion wasn't that big. And the lesion was very eccentric, which means that if you plan to do a DCB, there will be a kind of severe dissection. So having said that, considering even the FFR is low and territory is big, but the medical treatment for that diagonal branch lesion may not be that kind of bad decision for this.
So DW, how would you do that?
Is my personal opinion is BK Gu is expert in the.
Yeah.
I prefer BK
You wanna follow
Gu.
Dr.
Yeah, BK Gu.
But it's interesting is that,
OMT would be okay.
we've fixated on the number a little bit, 0.77, right? Because on our brain it was 0.80 is the cutoff. But if you look at the LED has been fixed completely, and this number is 0.84. So there is some drop of the FFR within the stent. And just proximal to the bifurcation was 0.94. So the difference from 0.77 to 0.84 is 0.07. So yes, it is positive in the traditional sense, but I would probably don't do anything in the diagonal at this point. You fixed two very big territory, the right quantity that you fixed a few days ago, and this big territory in the LED diagonal. The diagonal is much better, right? It was 0.5 something and probably lower if you really look at the restriction. So I would probably leave alone at this point.
Yes.
I would argue that the main problem of the FFR and the LED is the muzzle bridge and not the stent. The stent drop
He pulled
along
it back
the
all the way
stent
to
was
the
minimal.
proximal part, distal part of the stent. It was 0.84 still. So it was not, down there was 0.84. Because again, the bridge doesn't affect the average FFR that you measure.
Right. So anyways, we
What do you want to do?
We
Gary's
have,
Gary's
just
thinking.
1 minute.
limited time.
He's
and
shaking his head. Well, I don't know what it
we
means.
decided just to leave it alone. All right. Exact, explanation for that. The point we believe from between the 0.8 and 0.75. You may remember that. Jongpil made us some data initially 0.75 cutoff value, and so we analyzed a kind of a gray zone so between the 0.8 and 0.75. The regions offset actually no difference at all hard point concern. However, still there are a little bit higher concern of the region revascularization, something like that. However, I believe ischemic study.
Yeah.
The small vessel, small ischemic burdens, and in almost all cases in our recent practice, main branch crossover and remaining small jeopardy area, why not just medical treatment? That is our.
Yeah, I think this case is one of a representative case of the state of art PCR. We combine the imaging and physiology. Even during the PCR process, we have some dynamic thinking. Is randomization? We already done decision making.
Right.
However, during the PCR process, we do dynamic thinking is on the basis of imaging and the physiology value. That was, I think, a representative case.
So
This is the last
SJ
picture?
and DW, I
Yes,
think
alright.
if you use angiographic guidance, most people would not have IBIS the diagonal to start with.
Yes, of
They
course.
would not have done
Yes.
FFR
Yeah,
afterwards.
if this patient is angiographic guided
Exactly.
PCR, we just treat and then final optimization is
Right.
allowed in the diagonal.
Most people would just leave the
imaging.
diagonal alone. They say, look, this is moderate disease, and just that's it.
So still, if even if angio guided, you're gonna think about the database, small jeopardy marker. That is clinical decision making for angiographic, even angiographic findings. Anyways, we are really, this is the last one. So I'm very happy to have 29th TCTAP this year, and upcoming next year's meetings will have a little more exciting, preparing the program. And really thank you all. And Duk-Woo, would you,
Yes.
say something?
So,
for
and
our
I think this year some new area, Seung-Do Convention Center. I hope that everyone really enjoyed the new convention center. And I think the overall program was excellent, especially Professor Gary Mintz lecture is amazing. So, and the next year, we come back again, the Seoul, Gangnam area, and the 30 years anniversary. I hope everyone hope participate next year, our 30 years anniversary in the Gangnam COEX Center. And thank you for participating this year. I'm looking for every person to participate the next year, our TCTAP 30 years anniversary 2025.
Thank you very much.
Thank you for joining us. See you next week.
The reason that he made it up like is that he stands across the diagram. Right. Because if he had nothing.